Hi, and welcome to In Real Life. And it's my great pleasure to have Lysa Owen with me today. How are you today, Lysa?
I'm very well, thanks, Pete.
And Lysa's up in Scotland, and she's going to tell us a little bit about herself. So it's been my great pleasure to get to know Lysa over the last couple of years. Unfortunately, not had as much contact in the last year for obvious reasons, COVID reasons, but we're developing a good friendship. So, Lysa, tell us a little bit about yourself, please.
Yes, my name is Lysa, and I am a medical doctor by profession. But over the last decade or a little bit more, I have been very involved in medical education at the University of Dundee. And then for the last 3 years, I have been working on a collaborative project between the University of Dundee and the University of St Andrews called ScotGEM. And ScotGEM is Scotland's first graduate entry medical programme. And I've been the lead for an element of the course called the Clinical Interactions course. And that it's a bit like clinical skills, but I think as Pete will maybe want to chat a little bit more about why it's a little bit different from how clinical skills is delivered and what sort of content it is in other medical schools. So I've been leading up the clinical interactions course for ScotGEM, but I have just recently finished that job, just in fact this very weekend, and I'm heading off to another medical school where I'm going to be heading up clinical skills for another new graduate entry medical course, which will mean a big transition for myself and my family because we've got a big geographical relocation and also an exciting new programme to set up.
Yeah, well done. And as we were talking, you were saying about how when we went through medical school, certainly I was probably a little bit before you. I think it was old school medical school in one sense, wasn't it? And how it addressed certain aspects of medicine, but maybe some other bits weren't really included in that reality. So, and I know you talk quite a lot about that, don't you?
Yeah. So I did my medical degree in the 1990s, and I've worked in a whole range of different specialties, mostly hospital-based specialties and emergency medicine. I did for quite a long time. My clinical role now is in medicine for the elderly and geriatric medicine or care of the elderly. I know it's called different things in different places, and I took a fairly scenic journey to get from emergency medicine into medicine for the elderly. But one of the things that I think I gradually came to understand, both through my own medical practice with patients and as I began to think more about what I did and why I did it in the context of teaching students, was that I realized that the structure of medicine has been really the same. We've used the same way of teaching and training doctors, medical students, for about the last 100 years in both the USA and in the UK. It's sometimes called the Flexnerian approach, named after a guy called Flexner in the USA. And Flexner really pioneered something around about 100 years ago where where he really promoted the idea of medicine being very scientifically based, and that doctors, as practitioners, should be very well grounded in the physical sciences, in physics, in chemistry, anatomy, knowing all about the structure of the body, physiology, understanding the function of the body. And so medical education has very much followed this scientific or biomedical model where we thought about everything from the cell to how the body works. And for me, when I was a medical student and learning, things like communication skills were beginning to be recognized as being important, but tended to be treated as a little bit of a bolt-on, a little bit of something extra, maybe with a slightly pejorative idea that GPs were good at communication, so we'll let the GPs teach communication skills. And nearly all of my medical education was delivered by hospital specialists, by those in secondary care. So those were people who were highly expert and had a huge amount of skill and expertise, but only in a relatively narrow subject area. They dealt with people with problems of the cardiovascular system, or they dealt with people with problems in their respiratory system, or they dealt with people with problems with their gastrointestinal system, or they dealt with people with psychiatry, dealt with people with mental health problems. But it was very unusual to have a lot of exposure to areas of medicine that were more generalist, those who could deal with more than one problem. So the graduate entry medical course that I've been working on in the last 3 years has got a remit to create generalist medical practitioners. So those are doctors who can understand all of medicine, who can understand not just the different specialties of cardiology, respiratory medicine, and so on, but can also see the whole person and understand that person in the context of their community, in the context of their family, and so on. So I really was incredibly privileged to join a medical program that already had set the groundwork of the kind of medical education that I wanted to be involved in, the types of medical students who I wanted to inspire, because I had discovered that I needed to understand all of these things and integrate them in my consultations in order to really effectively connect with patients and to meet their needs and to have meaningful interactions with them. And so as a consequence of that learning experience for me, and recognizing the inadequacy of my own development and my own skills and expertise and the things that I had to learn a bit later, I wanted the students to have a better start. So I created this very integrated and very holistic clinical interactions course, where alongside learning the important physical and scientific approaches in medicine, like how to examine the heart or how to examine someone's breathing, or how to examine movement in a joint, or something like that, I also wanted to include those skills and background knowledge that students would need to understand the complexity, to understand that effective communication skills are completely integral with all of that, and also understanding the context of people in their community, understanding their previous experiences, and how that influences their sense of health and well-being.
I think it's fascinating. And how many years has this graduate entry program been running there up in Scotland?
So the Scottish Graduate Entry Medical course has been running for 3 years now, and we're expecting our first graduates next year. And although I am sad to be leaving the team here, I'm hoping that they'll send me an invitation to the first graduation next year, so that I can see how those students have learnt and grown and progressed and really flourished in their new roles.
I think it's a great story. And then your new job, it's you're starting up from scratch almost, aren't you? I think, is that right? So building a system. I think it's wonderful, because that's that whole psychosocial aspect of medicine that really, I remember when I went to medical school, we definitely regarded it as a sort of sideline, and we were, as you say, taught by the professors and the experts there. And like you, I had to learn the skills of interaction with people in their context. And one of the important things to say is this whole spirituality as well. That's an important bit. Most people within, I think still the majority of people within the UK would profess to have some spirituality as an important part of their life. And the General Medical Council and also the General Nursing Council have it in their guidelines that it's a requirement to take that spirituality into account for people's overall health and well-being, isn't it? And I know that you've been teaching your students a bit about that, about how to take a spiritual history and stuff like that. So could you explain that a bit to us?
Yes, I mean, I think that most medical schools do acknowledge that spiritual history as a package of finding out about someone's health and well-being. A spiritual history is part of that. But once again, a little bit like communication skills or understanding about adverse childhood experiences or whatever, it has tended to be treated as a little bit of a bolt-on for a particular group of practitioners or a particular group of students. And I think the majority of medical schools will address spiritual history taking and connecting with people and asking about their spirituality and the influence that might have on them. And it's tended to be very much restricted to palliative care. And I think that's the area that most doctors and students expect to have some kind of input with spiritual care. When someone's been diagnosed with a life-limiting illness, or when they're nearing the end of life, that's the time when most medical curricula will introduce to students, to learners, the idea that it's important to find out those spiritual aspects of care, what provides the person and their family with meaning, what gives them joy, what are their thoughts about nearing the end of life. And I think that's absolutely correct and legitimate and has its place. But I wanted to bring the aspect of spiritual care into more areas than simply when someone is nearing the end of life or when they have received a diagnosis of a life-limiting illness. And so I obviously working with medical schools, I want to be wise. I want to be guided by people who are credible and have expertise in this area. And so I looked for other areas and other places where it's established that spiritual care and understanding what provides someone with meaning, what their beliefs are, and what the beliefs of their community are, and how those influence them, are also important. And one of the areas, just by way of example, one of the areas that that I was able to do that and introduce that in our program is in a section of our program on addictions, and also the section of our program on mental health and mental illness. And it there are very good and credible resources, and one of the ones for listeners who are interested might want to look at is that the Royal College of Psychiatrists, who are obviously a highly regarded and respected body, have emphasised, they've put out a report and recommendations that say that any individual who is presenting to healthcare with any kind of mental distress or mental illness should have a thorough spiritual history elicited in order to find out whether that is a cause or a contributing factor. And the Royal College of Psychiatrists have stated very clearly in that guidance and in that document that many people who are diagnosed with mental illness may in fact be experiencing spiritual distress. And if you don't ask about it and you don't look for it, then you won't find it. And of course, we've heard such a lot, haven't we? Particularly during this last year, we've heard a lot from the media. As healthcare professionals, we all know that there's been a huge increase in both awareness and also prevalence of mental distress and mental illness. And so, therefore, I think there's a really strong imperative on all of us as healthcare practitioners to know, how do you take a spiritual history? How do you ask about someone's beliefs, about their values, and what brings them meaning in their circumstances? And the Royal College of Psychiatrists really supports that. And if maybe people are nervous, maybe people who are practicing Christians themselves who are worried about whether they're able and permitted to bring their beliefs and practices into the workplace, then this is really a very credible document for you to read, to enable you to say, actually, this is part of my provision of holistic care for all of the patients I meet. And we can do that wisely, and we can do that compassionately, and we can do that as a package along with all of the other ways that we look after people and care for them.
So if you were to give us a few pointers, how do you start a spiritual, how would you suggest people start a spiritual history? Because I think a lot of people would be engaging with this, say, yes, that's absolutely, but where do you actually start? How do you, because obviously, I think people are concerned about proselytizing, just that side of pushing their belief systems upon but other people. Basically, it's a discovery of what their belief systems are, isn't it, and what's important to them and how they can be helped. I think that's all right in understanding that.
Yeah, I think for people who would find that this is a relatively new area, one of the things that's maybe helpful is just as when medical students are beginning to learn to talk to people using a biomedical model, it's helpful for them to have a little bit of a script to start off with and some suggested questions, maybe a few pointers. And it's actually quite easy. If you just Google spiritual history taking, you'll find that there are 3 or 4 commonly used structures and models that maybe give you 4 or 5 questions and introductory ideas and questions that allow you to open up that conversation, and provide you with that structure. And then once you understand and you've tried that, then everyone will then adapt that and say, you know what, that's just a clunky phrase for me. It doesn't suit my personality type or the type of practice that I'm in, and you can begin to adapt that. So what I've done is I have offered just 1 or 2 very simple approaches and simple models to the medical students, and given them an opportunity to rehearse that in practice, either with role play or with simulated patients. And so I would suggest, maybe rather than me giving, suggesting people a particular script that maybe I've adapted for my practice, that actually you just literally Google spiritual history taking. It'll give you some primers, 3 or 4 questions, and you can have a look at that and say, the context in which I deal with patients, clients, service users, whatever, is this particular context, and I could imagine myself using a phrase like that to open this conversation. And when I teach medical students as well, I teach them, do you know what? It's just the same as asking someone about their chest pain and having a certain list of questions. If someone's got chest pain, then there are 3 or 4 set questions that I would advise the medical students to ask. And then if they find that they're then out of their depth, if they are unsure, what's the diagnosis? What's the treatment? How can I manage this? Then the suggestion is that if you then get a response which is beyond your own level of expertise, you can then refer the person with chest pain onto a cardiologist if it goes beyond your level of personal expertise. One of the things that as healthcare professionals we all need to be aware of is what are our own limitations. And I teach this to all medical students, not just those who do have personal faith themselves, but I tell them that it's part and parcel of something that every healthcare professional should be asking their patients. But it doesn't mean that we have to necessarily be able to offer ongoing care or treatment in that area. We can gather the information, and if we find that there is spiritual distress manifesting as mental health problems or manifesting as in other ways as non-specific pain in a particular physical pain in some area, instead of sending someone for blood tests and x-rays and CT scans and so on, if we identify that actually this may be spiritual distress, for those who don't feel confident or skilled in then helping address that and manage that, you refer on to someone who can, in the same way that we refer to other medical experts and specialists who have greater levels of skills and knowledge than we do individually. And as we become more mature in our healthcare profession, in our own professional esteem, we begin to realize, actually, I understand the limits of my knowledge and expertise and I can refer on. And I think that's something where what I'm introducing in undergraduate medical education has the potential to tie in with other elements of heaven and healthcare and ties in with other elements. So we'll have people who are experts, who are specialists in the provision of spiritual care, such as you're providing in Eastgate. So if my role is to disseminate the idea that all healthcare professionals, irrespective of the context in which they work, whether they work in secondary care settings in hospital, in primary care, in community-based care, in mental health, in physical health, if we could normalise inclusion of a spiritual history with every patient who we meet, sometimes we will identify spiritual distress, people who are having difficulty in making sense of their own beliefs and making sense of how that might be influencing their reaction to their experiences or their reaction to symptoms, or it might actually be manifesting as physical symptoms. We're then in a position to say, okay, that this might not be my area of expertise, but I wonder whether what you're experiencing is a kind of spiritual distress, and would it be of interest to you if I were to be able to offer you a referral to someone who has more expertise in that area than I have? And so if we see it in the same way that we see other elements of our medical practice, I think that's very liberating for people. And I've learned from colleagues and those who have more expertise than I have in this area, like Pete and the team. And I would encourage people to think of it exactly the same way as we would with anything else. If someone had a problem and I was referring them to an orthopedic surgeon, I would say to them, I think that maybe this is what your problem is, but it's not my area of expertise. But I would be willing to refer you on to someone who I feel has more expertise in that area. Would you like me to refer you to the surgeon? Would you like me to refer you to orthopedics to talk about your hip pain some more? They might be able to offer a hip replacement surgery, or they might be able to offer you a steroid injection, or they might be able to offer you and I might suggest from my knowledge of my colleagues what sorts of treatments might be available with this referral. I have the person's consent, their cooperation. We're partnering in me making my suggestion about what I think might be going on and making an onward referral. So that's the approach that I take when I'm teaching medical students, and I just want to encourage them to really normalize this. And my experience is that they've been very, very open to this. We know from various polls and opinions and asking people that even though conventional expressions of faith and attendance at church might not be common in our context in the UK and perhaps other countries, other viewers who might be watching, a lot more people will say that they do consider themselves spiritual and they do have some kind of spiritual awareness. So I would tend to encourage people to approach it with that language in the first place. Do you consider yourself a spiritual person? Have you had any thoughts about the things in your life that particularly bring meaning or joy to you? And we can introduce it in that sort of way. And people, the students who I teach, are very receptive to asking people if they consider themselves spiritual, and using spiritual care rather than maybe slightly old-fashioned terms like chaplains or chaplaincy or whatever, often can just open that doorway into initiating a conversation with someone.
I think that's brilliant. Very liberating, to be honest, Lysa. And I'm just thinking, what a need there is out there, and then obviously the opportunity to fill that need with, like I say, what we call chaplaincies and hospital chaplains and other side. And I know that some GPs actually have like similar helping. And just reminded me, actually, when I was a partner in general practice, I actually realised that a lot of my patients came to me, and really they didn't want anything medical. They just wanted somebody to listen to them. And I thought, well, this is great, and I don't mind doing it, but actually this takes up a lot of my time, and I usually don't have enough time to listen to them sufficiently. So I actually worked with a local church and set up a listening group, and I trained them myself. I said, your job is to listen, your job's not to give advice. And I had 6 volunteers from that church, and I used to send my patients there, and the patients absolutely loved it because they actually found that there's a need that was being met. I hadn't really thought about it before in the same like that spiritual care, but I was happy to refer on for people's needs benefit, and I think that's fantastic. I think this will be very liberating, what you're saying, for many people, and I think it just makes so much sense. This is a part of people's health and well-being. I can inquire about it, but actually I'm not the expert. I'm not the surgeon. Let me refer you. And again, it reminded me of what we did when we presented the Eastgate Healing Centre to 100 local GPs. Basically, we told them about what we could offer and offered it actually as a spiritual referral centre if they wanted to take benefit from it, the advantage of it being there, to take that workload off of them and be, if you like, the more trained in that area, I guess. So yeah, I think that's brilliant. And so as you go about this, then have you found that's helped you with your patients on your wards in the general medicine and then the elderly care wards? How's that going down?
Yeah, I gave maybe an example of how spiritual care influenced my practice. Maybe shall I maybe tell you that little story again?
Yeah,
so I was working in an intermediate care unit, so that was an area of the healthcare system where frail elderly people, maybe who'd had falls or who'd been in hospital for a period of time and had maybe lost their confidence and lost a bit of their strength and had maybe some ongoing medical problems, and who weren't quite ready to be home again, but didn't really require the services of the big shiny hospital. So I was working in an intermediate care unit, and I had I had a bit of time to spend with patients, and I didn't use a conventional spiritual questionnaire as such, but I did have an experience where I just had just a sense of me personally of just praying before I went to meet the patient, a new patient for the first time, and just praying and asking God to just give me an opportunity to listen well, to hear not just what she was saying, but what was behind what she was saying, and to actually make a really meaningful contribution to this woman's recovery. And before I went to see her, I had a look at the notes, and she'd had a fall, and she'd had a recent injury, and she was on a lot of painkillers for the recent injury. But I saw that she was also on a lot of painkillers for really long term, persisting pain that had been difficult to manage. And then she had this new pain from the injury on top of that. And for those of you who are healthcare professionals, she was on a cocktail of drugs that maybe you would be familiar with, people with difficult to manage and persistent pain. She was on amitriptyline, she was on a gabapentinoid, she was on sertraline, an antidepressant for her mood. She was on MST, morphine slow release tablets, plus some Oromorph for that breakthrough pain. So she was on really quite an unhelpful cocktail. And one of my areas of interest in as a medical practitioner was in de-prescribing and trying to help people do better and have better ways of managing their persistent pain. So before I went to see this lady, I just, a little prayer in the corridor, Lord, just help me connect with this woman. And I was just talking to her and finding out about her recent injury, about her medical background and so on. And then when we were talking, we would include, a bit of social history, a bit about herself. And she mentioned something about her divorce, her ex-husband. And I just had this little sense of just like a little nudge from the Holy Spirit, just explore that a little bit more. So I just paused for a second and I said to her, can I just ask a little bit more? Can I ask, was that an abusive relationship at all? And it just, it was almost out of my mouth before I'd really formulated, why I was asking it, how I would ask it, and so on. And she just paused and she looked at me and she said, yes, it was actually. And she then just took a few minutes and I didn't say anything. I didn't ask her any other questions. I wasn't in question mode. I was just there to listen. And she told me about a relationship she'd had with a husband who was vulnerable through alcohol, who was violent and abusive, particularly in the context of alcohol and so on. And I just felt inclined to just wait and to just listen. And I just let her speak about that and tell me about it. And then when she'd finished speaking, I just paused. I didn't say anything. And then we just moved on to other aspects of her care. But just in that moment, by asking her if she'd been in an abusive relationship and pausing for long enough to let her tell me, even just briefly, about what that meant for her, just gave us a connection in our therapeutic relationship, in the doctor-patient relationship, that when I then came on a little bit later in the consultation to say, look, you're on an awful lot of tablets for persistent pain. Are they actually doing you any good? Are they helping your pain? And she then was able to say, well, no, they haven't. I started off on a small dose and then I got bigger and bigger and bigger doses, and the pain didn't seem to be getting any better. So I was then getting bigger doses. And so I was then able to start conversation. I was able to use other tools a healthcare professional would use, things like Live Well with Pain and so on, where we would start to speak to someone about alternative ways of thinking about their pain and living well with pain. And during the few weeks that this lady was in the intermediate care unit in her rehabilitation and under my care, I went to see her a couple of times a week. we would review her medications and ask how she was getting on. She was really willing to try reducing and stopping these. And by the time she left the unit, she had reduced or stopped all of almost all of those drugs and had an onward plan of reducing or stopping those that she was still on. So, you know, for those of you who may be in general practice or psychiatry or mental health services, you'll know that sometimes helping people stop drugs that are unhelpful and are probably causing them worse side effects than they're actually doing good to manage the persistent pain or the insomnia or the anxiety or the depression. There are other more helpful ways to do that. And I just felt that actually that wasn't overt spiritual care. That wasn't me offering to pray for her or whatever. That was actually just me bringing kingdom wisdom and bringing a little bit of wisdom of the Holy Spirit to offer someone a better recovery rather than just increasing her drugs some more. So I guess maybe, Pete, that's something else that I would like to say. You know, when I came down to Eastgate and did a presentation at a previous Heaven and Healthcare conference, I told you that before I did that conference, I'd been praying and I said to God, you know, I feel really inadequate for this. And I paused and I felt God said, good. Because we are all inadequate, aren't we? And we don't, as people, as Christians in the workplace, whether it's in healthcare, teaching, education, veterinary practice, law, whatever your workplace is, you don't actually have to be doing remarkable things. You don't need to be doing big, you know, headline making miracles. Actually, it is, I think I'm learning that actually just by being there, you'll be doing some good. Just by asking the Holy Spirit to guide you and just take that little nudge to bring some wisdom into your teaching, wisdom into your interaction with someone, so that they leave their interaction with you feeling somehow a little bit better in themselves, even when they don't understand why that is. And so I want to encourage people who are listening and say, you know, I love to hear about miraculous and dramatic changes in people's health and well-being. But actually, sometimes it's little by little by little. It's getting up in the morning, turning up to your shift on time, being kind to people around you, just taking that extra moment to pull a chair up on the ward when you want to just nip in behind the curtains and ask a quick question and move on. Sometimes it's pulling a chair up and just pausing for a second and saying to someone, was that an abusive relationship? That enables that connection, that enables you then to bring good, to bring, you know, the good of the kingdom of God into that person's medical care at that point in time. So there's little things as well as the big things that can make a difference for us in our workplace, whether that's healthcare or something else.
Well, Lysa, that's phenomenal. We keep talking, and I'm sure we want to get you back, because I'm sure you've galvanized a whole lot of interest and questions, and that's been brilliant. And I'm sure this will be beneficial not just to the healthcare world, but beyond that. But we'll land this now, and look forward to actually doing this again. That'll be great fun to do this again. And praying that you have a great transition into your new job with everything and the move of the house and the family. So I look forward to that new adventure opening up in front of you. So we're going to finish this episode right now. And for everybody watching, we wish that you have a great week and a great day, whatever's going on in your lives. That take God with you, as Lysa has said, and just be happy to be carrying the kingdom of God in whatever way that means.